Hi, welcome to our first Facebook Live session as we discuss maternal-child matters. If you're thinking about being pregnant or you are pregnant, we encourage you to join our Facebook page right now and log in your questions. To date, we have received lots of questions and we thank you for that, and we will be going through some of those questions. But in the meantime, if you do have a question, please log in and we'd love to hear from you. I am Marissa Valika. I am the Director of Professional Practice, Maternal Child Care, and Critical Care at Joseph Brant Hospital. And this is my colleague, Leila.
And I'm Dr. Leila Mangalolu. I'm the Chief of Obstetrics and Gynecology here at Joseph Brant. So, shall we start with our first question?
Yes.
Perfect. So the first question reads, I have heard that Joseph Brant Hospital has a level 2B nursery. What does that mean?
So, just to keep things simple, Level 2B nursery is an indication where we are able to care for infants or neonates 32 weeks and greater, which means we are able to provide respiratory, certain medication therapy, and of course any type of intravenous therapy that a PREM baby would need, and or care for the neonate in ways that we need to manage complications. So we do have the skill level and ability to care for those infants with a skilled group of nurses and pediatricians caring for that neonate.
And from the obstetrical side of things from that means that we can accept transfers from other hospitals to help women who are 32 weeks and above. We'll take the next question. So our next question is it possible to have a vaginal birth after having a previous cesarean section? That's a great question and a big topic of conversation lately. So the short form for vaginal birth after cesarean section is VBAC. Here at Joseph Brant Hospital, we do promote VBAC, and it is certainly possible to have a vaginal birth after you've had a previous cesarean section. But there are certain parts of your history that need to be evaluated first before knowing whether you would be a candidate or not. So your obstetrical care provider would then review your previous history of your cesarean section and then talk about would you be a candidate or not. In addition to reviewing your history and determining your candidacy, we here also have VBAC information nights that are held every other month or so by one of the obstetricians, Dr. Jane Bailey, and one of the midwives, Candace Smith. So the two of them will host these sessions together, and it's free to the public. Welcome to come and have all your questions answered.
It's hard sitting in front of the camera and answering questions without someone being live in front of you.
Yeah. All right.
So our next question came to us stating, I want to develop a birth plan, but also want to be realistic that things might change. How much detail should I put into my plan? So I'll start off with responding. As a former L&D nurse and now as the Director of Critical Care Maternal Child, I do have my own experience with having developed a birth plan and managing birth plans and expectations of women coming into labor. Absolutely would encourage whether you're a first-time mom or second, third, fourth-time mom to develop a birth plan, because it does help to set the expectations you have and your loved one has of how you would like to manage your birth and labor. However, I would also allow and encourage some flexibility as complications arise or issues arise that need to be dealt with by your healthcare team. Having that flexibility allows you to mitigate any disappointment or feelings of failure. So as much as I encourage birth plans, I also encourage you to get to know your healthcare team when you come in and move through your labor with openness and willingness to try and attempt a variety of different labor supports.
And from obstetrical care provider perspective, so it could be any of your care providers, whether midwifery, family medicine, or obstetrics. We encourage to discuss women's expectations and what they would like and expect in their labor process. Part of our admission package that you get does have a preliminary birth plan in there with some information, but you're also welcome to navigate your own and write up something. My experience has been that we're all open to discussing what women want and what families want. Our view is that we want a safe mom and a safe baby at the end of the journey, and although things may be written onto a birth plan, it is, as Marissa had said, possibility that other unexpected events can occur, but those will all be reviewed and discussed with you thoroughly, obviously, before any intervention would occur. But certainly, safe mom, safe baby is the end point of any birth plan for any of us here on labor and delivery.
Absolutely, I agree. So for those joining us, my name is Marissa Valika. I am the Director of Critical Care, Maternal, Child and Professional Practice here at Joseph Branton Hospital, and you are joining us live through our Facebook session on discussing pregnancy and if you're thinking about being pregnant. And so we're welcoming any questions you have. We have received a number of questions already, but we do welcome you and encourage you to sign into our live Facebook page if you have any questions.
And I'm Dr. Leila Mangalolu, and I'm the Chief of Obstetrics and Gynecology here at Joseph Branton Hospital. So we just received a question from Karen. Thank you, Karen, for spending your time with us and sending in your question. What Karen writes is, if I need an episiotomy and don't have an epidural, will I get a local? So there's a number of ways to navigate this process. We traditionally don't routinely give episiotomies, but certainly there are some clinical circumstances where that would be needed or indicated. Certainly local anesthetic is available. We generally would inject into the perineum prior to making the incision for the episiotomy, and certainly local anesthetic, abundance of it will be used afterwards in order to keep you comfortable while we do the repair as well. For women who need an episiotomy, most women will have a tear naturally with a vaginal delivery. If a woman doesn't have an epidural through her labor process, we do have Entonox gas available as well that you can utilize while we do the repair as well. So we hope to keep you as comfortable as possible in managing that aspect for you. I hope that answered your question.
We received another question from Shannon. Thank you, Shannon, for watching and participating. Question reads, how does the hospital / labor and delivery department feel about using doulas? So from a nursing perspective, absolutely welcome any supports that are pertinent and encouraged and also valued to the woman and family who are coming into the labor and delivery department. I think it's really important to ensure that you personalize your experience, and on our end we do our best to ensure that we support all needs and expectations and those individuals that you feel are going to help you and support you through your labor process. So yes, we do welcome doulas. We have a large group of participation from doulas, midwifery, and other extended supports that we do welcome into the program and into our birth experience. It is your experience and we want to be sure to help support you with that. So thank you, Shannon, for that. I hope we did respond to your question. I don't know, Leila, if you had any other questions or response.
The other thing I wanted to mention from an obstetrical standpoint, of course, we encourage women to have the support people necessary for them, including doulas. Of course, they are welcome onto the unit. The other thing is our current labor and delivery, we allow 2 support people per women, but we are undergoing a redevelopment, so perhaps in the future, once we have our brand new labor and delivery suite, there might be more area as well to have further support people available, but currently we do have 2, just from the nature of the size of our rooms at this point in time.
Thanks.
Thank you. Another question. You guys are loaded into questions. This is great.
Yeah.
Do C-section deliveries accommodate skin-to-skin breastfeeding right after delivery? That's a fantastic question. So at any delivery, we encourage skin-to-skin, vaginal delivery and or cesarean section. So typically what happens, and we also do delayed cord clamping. So once the baby is delivered, provided that the baby is happy and healthy at the time of the delivery, at the time of C-section, we allow the delayed cord clamping to occur. After we traditionally do it to a minute, but the evidence suggests any time after 30 seconds is sufficient. So if we can accommodate that, then that's great. Once the baby then traditionally gets passed over to the nurse looking after the woman at the time of C-section, just to get kind of cleaned up, looked at, and then right away then brought to mom skin to skin. So as I'm doing my job on the other end of the curtain, finishing up the cesarean section, then the baby is on skin to skin on mom, and sometimes we kind of move our stuff back so that we can accommodate that. And as long as mom is feeling well to do that, then absolutely. And if it's the case that we can't, if mom is not feeling right at the time, then as soon as mom and baby are brought into our recovery room, breastfeeding is initiated, baby is skin to skin, So there's no disruption in that process with cesarean section, or maybe just for a brief second once the baby is brought over to the warmer for that one little look over before being brought over to mom. I hope that answered your question, unless you had something to add.
Just being a former L&D nurse, what we also would do if there was any complications with mom and mom at that particular time could not do skin to skin, we'd offer that, again with the premise that baby is doing well and it can come from the warmer out and has been assessed. We would offer that skin-to-skin contact with the significant other.
That's right.
Whether it's a woman, a man, we do offer that treatment because we do know that's what's best, and it's important to be able to do so. So I've seen many times in which mom is unable to at that point to do that skin-to-skin, and so we do encourage others to get involved in that care. So I hope that gives you a better picture of what we support here at Joseph Brant.
Great. Another question? This question is from Carly. So hi Carly, thanks for joining us. I'm currently 36 weeks and having period-like cramps as well as pelvic pressure, also mucus plug loss. What does that mean? My midwife hasn't been able to answer the question. Well, thanks for joining us, Carly. Congratulations on making it to 36 weeks. You didn't say whether it was your first baby or second baby, but either way, congratulations. It's an exciting time. So period-like cramps at 36 weeks is not uncommon. Sometimes you can also get a little bit of bleeding when you go to the bathroom, but as long as it's not period-like bleeding or heavy bleeding, then it should be okay. If the cramps, though, get a little bit that they're disrupting your daily activities, you find them quite unnoticeable, you are still preterm, so I would encourage you to be assessed. Even though we know babies born at 36 weeks tend to do quite well, but you are still considered in the preterm category, so I would encourage assessment. Mucus plug loss, many women can lose their mucus plug early or later or not at all or not notice. It doesn't really have much of a clinical relevance, but certainly if the pelvic pressure and the cramps are persisting, then I would ask your midwife to come and assess you or present to labor and delivery for an assessment. I hope that answered your question.
So we've got another question coming through. What amenities does Joseph Brant Hospital offer for laboring mums? Do you offer hydrotherapy? So yes, we do. In short, we offer a variety of different labor supports to help with pain management and comfort measures. We do offer hydrotherapy. We do know that presently our amenities are not at its best, and so we strive to ensure that that is available. However, we do have a redevelopment in the works, and we're very excited about this as it's important to us and our investment into women's health and ensuring that our labor and delivery meets the expectations of our community families and women who are currently pregnant and wishing to become pregnant. So yes, we do offer services. We do have nitrous oxide, which is a breathable gas that helps with pain alleviation. We have hydrotherapy, in which showers or bathing exercise is supported. We have the large exercise balls in which you could use to help support just a rhythmic movement. We offer a number of different massage techniques, etc. So I welcome any other questions about this, but do hope that we've answered your questions. And I do hope in the future we have a session on what's next and what we're doing here as far as our redevelopment project. So more to come about that.
And also with respect to other amenities offered, we do have mobile telemetry, so you're not, unless you have an epidural, which is not safe to walk with, but you can move about the unit as well, and we have a lot of moms managing their labor discomfort with ambulation and with walking, so we can monitor the baby while you're doing this. It can also be used in the tub as well, which is something new I just learned the other day, actually. I didn't realize that. But so something else that can be offered. Our redevelopment plans, as Marissa said, we're very excited about it. Each room we're hoping is going to have a shower as an available mode for hydrotherapy, and then a state-of-the-art tub room as well. Yes. That will have not a birthing tub per se, but a immersion tub for analgesia, as well as enough room in the environment to have your care provider, like your whoever's looking after you, as well as your support person as well.
And for those of you who are just joining, I just wanted to reintroduce myself. My name is Marissa Valika. I'm the Director of Critical Care, Maternal, Child, and Professional Practice at Joseph Branton Hospital. And you are joining our live Facebook session on maternal child matters and talking about pregnancy, or if you're thinking about being pregnant, we are answering and encouraging those to submit any questions you may have about pregnancy.
And I'm Dr. Leila Mangalolu. I'm the Chief of Obstetrics and Gynecology here at Joseph Branton Hospital. So we have another question from the group. Thanks again. This is from Jen. Thank you, Jen, for submitting your question. Jen states, I had my first baby at 38 weeks. I'm now pregnant with my second baby. Congratulations. Is it likely I will go into labor early again? Oh, the labor question. Of all the advances that happened in obstetrics, predicting when labor is going to happen is not one of them. So that's the time-tested question. So no, if you had a baby early the first time, it doesn't mean that the next time it's going to be that way. I was in a similar boat, had my first baby at 37 weeks, and the second one came a week or so later. So no, but certainly we say in obstetrics, if it tends to happen once, it's likely to happen again, or more likely to happen again. It'll all depend on what you're feeling at the time. If you're now starting to feel any, cramps as you approach the 38-week point, that sort of thing. But certainly, once you get to term, which is any time after 37 weeks, it'll come when the baby's going to come. So I hope that answered your question. I'm sorry it's not definitive because we have nothing to predict it, but great. Thank you for sending your question in.
Okay, we just got another question submitted from Alicia. Is there currently a ban or any limitations on older siblings visiting the hospital after delivery due to flu season? That's a really good question. No, we don't have a ban per se, but we do take into consideration individual situations in which someone, whether that be the patient, the family member, are ill. We do take a look at that and ensure that, of course, mom and new babe are in a safe area in which there's no likelihood of disease transmission or flu transmission. So is there a ban? No, but we would absolutely treat it on an individual basis if there was some sort of outbreak or concern that this potentially could harm the recoup of mom and babe.
And the other thing to remember as well is that when babies are born, they don't have the immune systems like we do, and we develop over time. They do get what we call a passive immunity from mom, but we certainly don't want to have anyone active with the flu visiting our families and our new babies. But there's certainly no ban at the moment. Another question?
Thanks, Alicia.
All right. My partner and I have been trying to get pregnant for about 6 months. At what point should we seek assistance from a fertility specialist? Well, that's a great question. The other thing is that there's, to be a little bit more specific, there's some extra information that would be required. So certainly age is a huge factor on the timeliness to referral to a fertility specialist. For example, couples in their late 20s wanting to have a baby, we usually encourage timed intercourse for approximately a year before there's any type of investigation. However, a couple, particularly a woman in their mid-30s, if they're doing timed intercourse, we would certainly recommend that for a 6-month interval of time, and then if not successful after that, to then proceed with a fertility specialist. And that's just because we want to get the pregnancy process happening a little bit quicker, because we know that fertility rates do decline as women get into their mid to late 30s. So we want women to be investigated and to be sure that they can accomplish their fertility desires for their family.
The next question, so we really appreciate all the questions coming in.
Yeah.
They've been great thus far, so thank you. When do you typically schedule a repeat C-section, and how long is an uncomplicated stay afterwards? Another great question. Leila, I'm going to leave that to you.
So newer evidence suggests that we should be doing our repeat C-sections at 39 weeks and onwards for standard repeat C-sections, uncomplicated pregnancies, and that comes from information showing that babies born at 39 weeks by a repeat C-section tend to transition from being inside of mommy to outside better, as opposed to a baby born at 38 weeks or less. Before we used to book them at 38 weeks, but now the standard is 39 weeks. And then everyone is different. So our booked C-sections are at 8 a.m. in the morning. So some women, it's, second baby, it's a booked planned C-section, so you haven't gone through the stressors of being in labor when you've had the C-section, so recovery can be a lot quicker. Women and families can go home at 24 hours. And for sure, we make sure that baby is breastfeeding well, all the baby checks are done, mom is meeting her discharge criteria as well. But certainly eliminating the labor part of the equation with C-section helps make the recovery a lot quicker. But certainly all of the postpartum checks, obviously we make sure that mom and baby are both ready for discharge, but certainly it can be as soon as 24 hours post. Thanks for your question.
Yeah, and just to quickly add to that, from a nursing care perspective, the nurses encourage mom, when safe, to begin ambulation. So we historically, in years ago, you had a time period of rest, a bed rest, in which a mom did not ambulate. Whereas now we try to ambulate because we do know the recovery period is lessened when mom starts to ambulate more. So I just want to add that in. So if you're encouraged to ambulate, there's a reason behind that.
So another question, what supports does Joseph Bryan Hospital have in place to support breastfeeding for new mothers?
So as a program, we offer a variety of different services, from obviously pre-birth to post-birth, and included in that is a breastfeeding clinic in which we have 2 experienced lactation consultants running a program 6 days a week for moms interested in breastfeeding. And that clinic runs during the day and on holiday hours to support moms who are new to breastfeeding or have breastfed before, and that process of establishing a breastfeeding regime. And so the 2 lactation consultants will work with the mom to ensure that there's a good pattern. We'll also work with the families to identify and educate families on signs and symptoms of what to watch for if a baby's not feeding well, or if there's issues with milk production, etc. So the team doesn't work in isolation. They also partner with our experienced nursing staff as well as our pediatricians if there is any likelihood of a complication occurring. So I encourage those who are thinking of breastfeeding to really come out and maybe perhaps look at our clinic and be able to speak to one of our lactation consultants. They're wonderful. They're a great asset to the team.
I couldn't agree more. I use the breastfeeding clinic myself with my second baby. But the other thing is that breastfeeding and support doesn't just start once you leave the hospital. Like even in the room that you deliver your baby in, whether it's C-section and or standard labor room for a vaginal birth, breastfeeding is initiated right away. So our labor and delivery nurses are great supports in initiating early breastfeeding. Our postpartum nurses, once you transition from labor and delivery to postpartum, are excellent resource in helping you get breastfeeding established. The lactation consultants even come to the unit to see every woman. You don't have to just go to the breastfeeding clinic. They see you on the floor postpartum as well. And then once you're discharged from hospital, there is that breastfeeding clinic available as well, which is excellent. Doreen and Karen are amazing. So
Yes.
I hope that answers your question. All right, so another question. What are the primary factors for a pregnancy to be considered high risk? I got married late in life and we are interested in starting a family. So that's a very relevant question, and thank you for it. We are seeing a trend now, like lots of women in reproductive age are, establishing their careers, and baby planning and fertility planning comes a little bit later, and that's not an uncommon practice. So there are certain indicators, both maternal, so mummy factors and or baby factors, that can make a pregnancy high risk. So your obstetrical care provider, whether it's obstetrician, family doctor, and or midwife, would review your own maternal history and identify any flags that would then perhaps precipitate ongoing investigation. There's also, and what we have access to in our LHIN, we have a great working relationship with the prenatal diagnosis clinic as well as the high risk maternal fetal medicine group at McMaster. So that's one aspect. The other one is there can be fetal concerns that can make a pregnancy more high risk. So, any kind of growth issues, congenital issues, genetic issues. And again, we work closely with our colleagues at McMaster under these circumstances. When we talk about age, the concept of late maternal age, before they used to put it at 35, but whoever would say that a mom is late maternal age at the age of 35 is offensive. So now it's been changed to age 40. So late maternal age is now age 40. So all women approaching the age of 40 will have a conversation with their care provider about surveillances a little bit more surveillance that we do in pregnancy with ultrasounds to ensure that the baby's growing properly, associated risk factors to mom like blood pressure diseases, diabetes, those types of things that we would monitor for. We also would talk about having an early delivery because we know that the placenta, no one likes to hear the word stillbirth, but there is the possibility of a late term stillbirth. So usually for moms who are 40 at the time of delivery and or approaching 40, we would have a conversation about have a baby by the time your due date arrives, and sometimes that does mean induction of labor. Other associated things with late maternal age can be increased risk of genetic abnormalities like Down syndrome. So you would have conversation with your care provider about the available genetic testing to you. Hope that answered your question. Another question. I'm an avid runner and I try to do multiple marathons in a year. At what point prenatal should I stop running, and how soon postnatal could I start training again? Well, kudos to you for running a marathon.
Yeah. Not happening.
No.
Boot camp.
Yeah.
But not running.
Or a HIIT class or something, but not marathon. So that's amazing that you're able to do that. So exercise is certainly encouraged in pregnancy. If you look on the SOGC website, there's lots of patient information on exercise in pregnancy. But essentially, we want you to stay active, but not to overexert yourself. So pregnancy itself takes up a lot of our calories. And when you do significant training for marathons or other types of events, a lot of that calorie expenditure will be taken away then from baby. So the general rule of thumb is exercise to the point where you can have a conversation with somebody. I probably would, and be also considerate as your uterus starts to grow with baby, your center of gravity is going to change as well. So you don't want to do anything that you could fall or injure yourself and or then the baby as well. So we don't recommend running a marathon in pregnancy, but certainly exercise is encouraged to help eliminate other risks in pregnancy, like diabetes, for example. And then just keep it to the point that you're doing exercise, but not to the point where you are completely gassed at the end of it.
Yeah, I agree. And it does, some form of exercise throughout your pregnancy does assist with an easier transition in labor.
Absolutely.
Again, that's a general statement, but I have noticed in my own experience that generally tends to happen. Someone who's a little bit more avid towards exercise tends to have an easier transition through labor and the stresses of labor. So I hope that answered your question. Again, for those of you who are joining us, my name is Marissa Valika. I'm the Director of Critical Care, Maternal, Child, and Professional Practice at Joseph Branton Hospital, and you are joining our live Facebook session on Maternal Child Matters, and we are speaking today about pregnancy or thinking of getting pregnant and questions around those particular topics. And with me I have Dr. Leila Mangaloo.
Yep, and I'm Dr. Leila Mangalolu. I'm the Chief of Obstetrics and Gynecology here at Joseph Brandt. Thanks for joining us. Do you want to take?
Yeah, I'll take the next one. So at what point should I start taking prenatal vitamins? Should I start while we're trying to get pregnant or once I am pregnant?
So that's a great question. So we know some pregnancies are planned and some are not. So we do encourage that all women of reproductive age group should actually be on a prenatal vitamin as their multivitamin, because it's encouraged to have the prenatal vitamin on board prior to conceiving, at least 3 months prior to. And one of the main ingredients in the prenatal vitamin is the folic acid. So for Generally, healthy women, 0.4 milligrams to 1 milligram of folic acid is contained in the prenatal vitamin, and that would be sufficient. And what folic acid will do is help with the development of the neural tube, so basically the brain and the spinal cord. So it's encouraged to have it on board beforehand. Obviously, if you're not taking a prenatal vitamin as your multivitamin, then it would be encouraged as soon as you find out that you're pregnant to start taking it. It's also encouraged to take it all the way through at least the first trimester, because that's when the neural tube is forming, but then also through the remainder of the pregnancy and postpartum as well while you're breastfeeding. There are other women who have other medical conditions like epilepsy, obesity, type 1 diabetes, who probably should be on a higher dose of folic acid, and they can talk to their healthcare provider about that.
That's great. Thanks for all the questions coming through. We've just received another one from Lisa.
I'm going to hand that to you.
Okay then. I recently came on a tour of your facilities. Are there plans to update the space? So Lisa, that's a really great question, and I did allude to it in another question, but I didn't expand on that. So the answer is yes. Joseph Brant Hospital, with the support of the foundation and our senior team, have identified a great investment opportunity to expand and renovate our labor and delivery area. We do know currently our amenities are
Dated.
dated is a good word. Dated is a good word, unless you like rose-colored paint walls. Yes, dated is a good word. But we do keep our facilities nice and clean. However, there is absolute need for reconstruction and redevelopment, in which we are along that journey of designing at this point. And we do have the substantial support from our senior team and foundation to move ahead to do so. We have been avid cheerleaders to, along with the support of our programs, to have this completed. Our midwifery group, our physicians, our pediatricians, our nursing staff and allied health teams are all supportive in moving forward with our redevelopment project, and will all have a stakeholder role in the design of our new unit.
Yeah, so our whole second floor, so labor and delivery, is situated in the old tower, which is now referred to as the North Tower, is undergoing redevelopment. Our postpartum floor is complete. The new nursery is in the process and will be completing in the next few months. And then from my understanding, we're kind of next in queue, but the whole area will be a redeveloped maternal child area. So exciting times for our team to come.
Yeah, and just to finish that, we're hoping that we'll have another session, perhaps maybe another live Facebook session on maybe focused on redevelopment, if that's the need. But just wanted to emphasize that our new space is looking at expanding our hydrotherapy amenities, as well as creating more of an open space for both families and the woman laboring, as well as connecting to our NICU, which is being currently in development, so that there's more of a transition space and I guess a less of a broken up model in which you probably just toured, and we're very separate at this point in time. So I hope that answered your question, Lisa, but yes, in short, we are.
So another question, it says, I really would like to use a midwife. Does Joseph Brant Hospital support the use of midwives? In short answer, yes, we do. So we have a great midwifery team here, the Burlington and area midwives. There's a group of 14 of them, and they have a large volume of clients that come through Joseph Brant. They're an excellent team. We work very closely with them as the obstetricians. Our nursing team works well with them. So it's a very interdisciplinary team, and very seamless movements from midwifery care to obstetrics to nursing, all integrated together. So absolutely. And if you're interested in a midwife, then I would encourage you to look to the Burlington and area midwives.
Great. We have another question coming through. I'll probably get Layla to answer this, but should I refrain from drinking alcohol when trying to get pregnant? That's just a really great question to ask, because that does come up often.
Mm-hmm. So I would, we, in anticipation of achieving pregnancy, we all want to make sure that we are in our healthiest time. So not only, limiting, I wouldn't say that you have to abstain from alcohol, but certainly limit the alcohol intake. Try to increase your exercise, modify your diet so that you have a healthy diet going into the pregnancy as well. But certainly, if you have regular periods, and if you miss a period and you're actively trying, you're likely then to do a pregnancy test soon. So then I would say, if you're at an event and you'd like to have a glass of wine or a beverage of your choice, then I would say that would be fine. But certainly, women tend to start to decrease their alcohol intake when they're actively thinking about trying to conceive. So this is our last question for this session, and we'll say a few words in conclusion, but thank you for submitting all your questions. This has been a great conversation. So this is our last question. Says, I've been deemed as a high-risk pregnancy and require additional ultrasounds. Is there any risk to my child? So short answer is no. So many pregnancies require ongoing ultrasound assessment for things that we've kind of spoken about earlier, whether it's maternal indication and or fetal indication. Some people as frequently as every 2 weeks, every 4 weeks, and then towards the end of the pregnancy every week. But there's never been any evidence to suggest that ultrasound is detrimental to fetal development. So if you're encouraged to have an ultrasound to evaluate fetal well-being, I would not have any hesitation to do that.
Yeah, I had several too, so I did also fear that and asked a very similar question, even with my nursing background. So thank you for asking that question and bringing it forward.
So I guess this is it for our,
I feel like
our first...
Layla and Marissa.
Layla and Marissa. Thanks again for taking your time over your lunch hour to submit your questions. We really appreciate it. We hope that in the future we can have a follow-up session with you, and we hope that we see you on our labor and delivery suite. Thanks again.
Bye.
Bye.